now we're going to talk about imaging of the liver, one of my favorite topics. It's a little bit hard to fit this in a 30-minute talk, but we'll go try to teach you a couple of things that will be relevant. So I broke this into 3 sections. The first part is going to talk about diffuse liver disease, really take 2 things, just fatty liver and iron deposition disease. And we'll talk a little bit about FNH versus adenoma. And then finally, we'll finish up with imaging lesions in patients at risk for developing HCC. So started off, we'll talk about liver disease. Diffuse liver disease nowadays always starts off with a slide on non-alcoholic fatty liver disease. And the point here is that people are having more fat deposition in their liver, and that will lead to fibrosis and finally cirrhosis, which can have significant causes of morbidity in these patients. And so how do we image fat in the liver is very important in terms of screening these patients for this disease. So there's a number of ways that we see steatosis on imaging modalities, right? We're frequently seeing on ultrasound the diffusely hyperechoic liver that attenuates sound, right? So we don't see through the liver very well. We frequently call that on ultrasound. On CT, on the other hand, we're looking for things that are low density, right? Fat is low density, so on a non-contrast liver, if the liver's less than 10 Hounsfield units than the spleen, we can call fatty liver. On portal venous phase CT, if it's less than 25 Hounsfield units than the spleen, then we can call fatty liver. And there's obviously many things that can cause fatty liver beyond non-alcoholic fatty liver disease, but we also have chemotherapy. And when we're imaging patients on chemotherapy, we frequently see significant fatty liver disease, patients on steroids. Early hepatitis can also look like this because of the edema, not because of the presence of fat. And then amyloid and glycogen storage diseases can also mimic this appearance. On MRI, which I'll talk about a little bit more in the next couple of slides, we're looking for loss of signal on in and out of phase images. And then also, obviously, if you use spectral fat saturation, if you look at a non-fat satted to a fat satted image, you'll see loss of signal in the liver in patients who have fatty liver. So here on CT, on the left side, you can see that the liver measures 9 Hounsfield units compared to 47, so that would be diagnostic of fatty liver. On the portal venous phase on the right, you can see this patient has severe fatty liver, right? This is a portal venous phase, Hounsfield units measuring -3 compared to 162 in the spleen. That's not even borderline fatty liver, that's severe fatty liver disease, and it's enlarged with the amount of fat. So let's talk for a second about the MRI appearances, because this is important when you're thinking about fatty liver versus iron deposition, right? So when we excite protons, they're always in phase at the time of excitation, and the precession frequency of your protons obviously depends on the Larmor frequency, which is dependent on magnetic field strength. But at the same magnetic field strength, the protons of fat and protons of water will precess at slightly different frequencies, and we could take advantage of that because the difference in frequencies determines when those protons will be in and out of phase based on a delay from the excitation. So this point here is when water and fat are in phase, and this point here is when water and fat are out of phase. And it has in phase and out of phase because fat and water precess at different frequencies. Okay, so when you sum up the phase or the amplitude of signal of fat and water, they give you a net signal. And it's the net signal that gives us the signal intensity that we're imaging on MRI. So in this case, we're looking at an image of a voxel that has 50% fat and 50% water because the amplitude in fat and water are the same. Okay? So when you look at the out of phase, you'll have 0 signal intensity in that voxel because they completely cancel each other out. This is in essence what creates the India ink artifact that we see on out of phase imaging. Now, if we take an example where there's only 20% fat, then the fat cancels out 20% of the water signal, and we actually lose 40% of the signal intensity of that voxel. So the amount of decrease in signal intensity in the out of phase is related to the amount of fat within the voxel. Then we can take these images and create out of phase and in phase images because we can rebin them, and we get images like this, classic in phase and out of phase images where you have your India ink artifacts surrounding all fat water interfaces, because at that interface we have 50% fat, 50% water, and that voxel cancels each other out, gives us the India ink artifact. And then you can take in and out of phase images. Here on the right, we have the out of phase image with the India ink artifact, and you can see heterogeneous fatty liver throughout the liver as demonstrated by signal loss compared to the in phase image. Okay, very easy way to diagnose the presence of fatty liver. Now, on the other hand, we do have iron deposition disease. So let's remember With iron deposition disease, you want to step back. There's two types of iron deposition disease, right? We have hemochromatosis, or primary iron deposition, right? So this is going to be hereditary and is due to increased intestinal uptake of iron. And what happens in these patients is actually we get injury to the reticular endothelial system, so the iron doesn't deposit in the normal biodistribution of iron. It goes to the liver in the hepatocytes and to the pancreas instead of normally going to the spleen, bone marrow, and liver. Okay, so it's a slightly different biodistribution because of the fact we have injury to the reticular endothelial system. Hemosiderosis, on the other hand, or secondary hemochromatosis, is typically due to overload of iron from IV transfusions. Okay, in this case, the reticular endothelial system hasn't been injured from chronic high levels of iron, and so the iron goes to the liver, the spleen, and the bone marrow. Okay, so two types of iron deposition disease with slightly different biodistributions, both of which involve the liver. So there's a number of ways to image iron deposition as well. On CT, you can actually see increased signal density or increased density on CT. And normally the liver is between 30 and 70 Hounsfield units, but when you get above 100 Hounsfield units, that's abnormal and should make you think of things such as iron deposition or other rare things as amiodarone toxicity, thorotrast, or Wilson's disease. Anything that deposits dense molecules into the liver will increase the density of the liver. Amiodarone, obviously, with iron, Wilson's disease with copper, etc. On MR, it's slightly different. We actually have decreased signal intensity on T2 and T2 star weighted imaging, right? So the iron causes, in essence, field homogeneity, and so we have signal loss as you go out in your echo time, okay? So we have decreased T2 and T2 star signal intensity, and so that's going to be really important because on in and out of phase imaging, the opposite is going to happen as to what you see in fat, and I'll go over that in some detail. So here's an example of a patient with a dense liver. This case happens to be amiodarone toxicity. His liver measured 150 Hounsfield units, obviously very abnormal. Anything above 100 should make you consider one of these diagnoses. So to go back to this diagram I showed you earlier, there's a slight difference here, right? The first diagram I showed you of in and out of phase, proton spinning, the amplitude of the protons stayed the same over time. Okay, but the amplitude of signal obviously decreases during your echo time, right? It decreases due to T2 star effects or dephasing that can't be regained in a gradient echo. So your T2 star causes decreased signal intensity over time, and therefore during your in phase time point, you'll have less signal intensity than during your out of phase if there's iron present. Okay, and this leads to images like this. This is a patient, that doesn't really show up very well, but a patient who has severe iron deposition in their liver, and you can see on the right we have the in-phase image has lower signal intensity than on the left, which is the out-of-phase image. So it has the exact opposite effect that you would normally see in the setting of fatty liver. Now the point here also that you should note is that the spleen doesn't lose signal intensity, so this would be consistent with primary hemochromatosis, right? When you have iron transfusion, hemosiderosis, you'll have reticular endothelial system biodistribution, so the spleen will become dark as well. So here again, you can see the liver's dark on T2 weighted imaging as well. The spleen is not dark, again, primary hemochromatosis. Don't go through this slide in too much detail. It's important to remember that fat and iron have opposite effects on in and out of phase imaging, which makes measurement of fat content in the liver very inaccurate using in and out of phase imaging. So therefore, the manufacturers have developed new techniques. So this is called proton density fat fraction. On GE scanners, it's called IDEAL. And this way, they use multiple echoes. Instead of just in and out of phase, they acquire 3 or 4 more echoes. And then you can use that to tease apart the iron content and the fat content within the liver, very accurately providing your clinicians with temporal changes in fat and iron in ways that you couldn't do with an in and out of phase image. So now we'll talk a little bit about the FNH versus adenoma, which is always a fun conversation. So focal nodular hyperplasia, we're familiar with these, right? They're typically incidental in young women associated with oral contraceptive use. The one other place we see it actually quite a lot is in patients who are on chemotherapy, right? Chemotherapies that injure the liver will lead to sort of, in essence, nodular regenerative hyperplasia, which is identical in essence to focal nodular hyperplasia. So chemotherapy patients will also develop FNH. The classic finding is a lesion is arterially hypervascular that in essence fades on T2 weighted imaging as well as delayed post-gadolinium contrast or post-iodinated contrast imaging. It has a characteristic lobulated appearance as well as a central scar that we'll talk about in the next slide. So here's a classic FNH using extracellular contrast on MRI. The key here is that it has a central scar. You can see on T2 weighted imaging down here, we have this hyperintensity centrally with a stellate appearance, classic appearance of FNH. That scar is dark on the dynamic contrast enhanced phases, so the arterial and portal venous phase. But when we get out to the 10-minute delay, that scar then collects the extracellular contrast because there's a lot of interstitial space, so it accumulates in the fibrosis of the scar over time. Okay, classic appearance of FNH with extracellular contrast. Now we should introduce the term hepatobiliary contrast. We're all familiar with this by now, right? Eovist or gadoxetate is the characteristic hepatobiliary contrast agent. This is an agent that if you go out to a delay, it gets taken up by the liver, so the liver becomes hyperintense relative to the hepatic vasculature, okay? So the key point here is if you want to see if a hepatobiliary phase is diagnostic or adequate, you compare the hepatic parenchyma to the blood pool activity, and the hepatic parenchyma should be hyperintense to the blood pool activity. So hepatobiliary phase. Of note, you should remember Multihance is actually technically also a hepatobiliary agent, but the amount of biliary excretion is only 5% of the agent, so you have to wait 1 to 3 hours after injection to get a hepatobiliary phase. It's not that useful in regular workflow in a busy practice. So here's an example of metastatic carcinoid using hepatobiliary agent. This is actually really sort of the prototypical use of hepatobiliary agents. It's looking for metastatic disease within the liver. Mets don't contain hepatocytes, and so they're pitch black and dark on the hepatobiliary phase, so you get very good detection. And here you can see this carcinoid is hypervascular, washes out, or becomes slightly hypointense in the portal venous phase. Carcinoids classically are restricted on diffusion-weighted imaging, and then dark, pitch black on the hepatobiliary phase because they do not contain hepatocytes. Lesions that don't contain hepatocytes are dark on the hepatobiliary phase. And the key point with Eovist or hepatobiliary phase imaging is that we have a very high sensitivity for small metastases. It's the best way to see small metastatic disease. Colorectal cancer, very good. Pancreatic cancer, neuroendocrine tumor. This is the best way to see small metastatic disease in the liver. Now, FNH on the hepatobiliary phase is slightly different, obviously. So here's a FNH using Eovist. On the top left, again, you see this sort of lobular lesion that's arterially hypervascular. It'll slowly fade on the late arterial and the portal venous phase. On T2 weighted imaging, you see that classic hyperintensity in the scar. The lesion itself, in this case, happens to be slightly hyperintense on T2 weighted imaging. But the characteristic appearance here is on the hepatobiliary phase. Where on the hepatobiliary phase, the scar is dark. So this is the opposite of extracellular contrast. The scar is dark because the blood pool clears so quickly with hepatobiliary agents that there's not enough time for the gadolinium to leak into the extracellular space of the scar. So the scar is dark on the hepatobiliary phase, just like the blood pool. And the lesion itself is iso to slightly hyperintense to the adjacent hepatic parenchyma. And it also has a very characteristic reticular appearance. So those ducts, you can actually see the ducts extend throughout the lesion much better than you would see on an extracellular contrast study. Okay, so very characteristic appearance of FNH, very easily characterized on hepatobiliary phase imaging. Now, on the other hand, we have the adenoma. The adenoma, I think, is sort of misunderstood because it's a very heterogeneous population of lesions, which I'll talk about in a second. But we know its association with hemorrhage, particularly with larger lesions. They can contain fat, both microscopic and macroscopic. They can have malignant degeneration and are associated with multiple diseases, most commonly, again, with women on oral contraceptives, but also men taking anabolic steroids or patients with glycogen storage diseases. Now, this I think is really important, more so to realize that adenomas have different types of appearances, and their appearances can be sort of characterized into the pathologic subtype of a lesion. And when you understand the types of adenomas, I think it becomes much easier to interpret the imaging, because instead of all these different types of appearances, you can sort of put them into these different categories. So the first type is the inflammatory adenoma. This is what is most common. It has a risk of bleeding and malignancy, and the characteristic appearance is T2 hyperintensity and intense arterial enhancement. And I'll show you a case of this. The second type is difficultly stated as an HNF1 alpha subtype. Don't really worry about the name so much, but just realize that there's a second type. This one only occurs in women who are on oral contraceptives. And this one has no risk of malignancy. Okay, so this is really important because it has a different type of outcome compared to the other types. The key component here is it contains lipid, microscopic fat, and it has much more mild arterial enhancement and milder T2 hyperintensity hyperintensity compared to the inflammatory subtype. And then finally, we have this beta-catenin type. This is the more sort of aggressive looking ones. It has macroscopic fat hemorrhage. It's really most commonly in men, patients with glycogen storage disease, and this one doesn't have good unique features, but luckily it's the least common. So again, inflammatory, T2 hyperintensity arterial enhancement has a risk of bleeding and malignancy, whereas the HNF1 alpha contains microscopic fat in women on oral contraceptives. So here is an example of a classic inflammatory adenoma. You can see clearly this very bright T2 high signal intensity of the lesion. It demonstrates brisk arterial hyperenhancement. And if you look on in and out of phase imaging, there's no evidence of signal loss because there's no microscopic fat. And then on hepatobiliary phase, it's slightly hypointense. So adenomas are hypointense on the hepatobiliary phase compared to FNHs, which are going to be iso to hyperintense. Okay, so this is the inflammatory adenoma. The most common type of adenoma has a risk of bleeding and malignancy, T2 hyperintensity, brisk arterial hypervascularity. Okay, we'll finish up with a quick discussion on lesions in at-risk patients. Okay, so this is actually what we do the majority of the time with liver MR is looking for HCC. So with all MR, the most important thing always is to know your patient history. With FNH, you need to know if it's a woman on oral contraceptives. Same with adenoma, you need to know if they're glycogen storage disease. With HCC screening, you need to know why they have a risk for HCC, because that's going to bring HCC much higher in the differential diagnosis. So at risk is defined as patients with hepatitis B or C. Hepatitis B patients, importantly, can develop HCC in the absence of cirrhosis, where hepatitis C patients typically require the presence of cirrhosis to be at risk for HCC. And then other causes of chronic injury to the liver, biliary cirrhosis, hemochromatosis with cirrhosis, et cetera, will also put you at risk for developing HCC. Okay, so it's very important to realize that at-risk patients, who they are, and it will really make you think of HCC first. I want to make one comment on the term regenerative versus cirrhotic nodule. Historically, like when I trained, we were told all these things in a cirrhotic liver are called regenerative nodules. They've actually changed the terminology. I don't know if it makes a difference in practice, but we call them cirrhotic nodules now. And the reason for that is these nodules in the cirrhotic liver are actually regenerating and becoming ischemic and dying in a cyclic fashion. So they're both ischemic and regenerative at the same time, so they're not truly regenerative nodules. For example, in Budd-Chiari, you get true regenerative nodules where you get new vascular flow back to the liver, you get a big fat regenerative nodule. Those are very different than what we're seeing in cirrhotic lesions. Cirrhotic nodules should all look the same in the background liver. So here's a case of cirrhotic nodules. They're typically T2 hypointense and slightly T1 hyperintense, and they're all the same across the liver. As compared to the HCC here, that's posterior to the liver in segment 6-7, you can see it's mild T2 hyperintensity and it has washout appearance. So cirrhotic nodules should all look the same, slightly dark on T2, slightly bright on T1. That's in distinction to the dysplastic nodule. Okay, so the term dysplastic nodule, pathologically, when they cut the liver, they use the term dysplastic nodule just to say that nodule looks different than another nodule. It has no other meaning than just a visual, gross pathology of looking at the nodule when they slice the liver. Okay, that's what a dysplastic nodule is. So on imaging, what we do is we interpret that as a nodule that looks different from adjacent cirrhotic nodules. Okay, and these include both low-grade dysplastic nodules and high-grade dysplastic nodules. Low-grade dysplastic nodules, in essence, have no risk of becoming HCCs, so there's no cellular atypia, whereas high-grade dysplastic nodules are more likely to develop an HCC over time. But the term dysplastic nodule includes both of them. So here's an example of a siderotic nodule, which is a type of a dysplastic nodule. Siderotic nodules are T1 hyperintense and T2 hyperintense relative to adjacent nodules. And you can see how this one nodule stands out as different compared to the adjacent nodules. Okay, so it's a dysplastic nodule because it's different from adjacent nodules. It does not have any characteristics that would indicate it being a HCC. Okay, so siderotic nodule is a low-grade dysplastic nodule. Now here's a different nodule in this liver. Here you can see it's maybe slightly T2 hyperintense and then doesn't really have any arterial hyperenhancement or portal venous phase washout. But the key point here is it's slightly hypointense on the hepatobiliary phase. So dysplastic nodules that are hypointense in the hepatobiliary phase are indicative of high-grade dysplastic nodules, which have a much higher likelihood of developing into hepatocellular carcinoma and subsequent imaging. So this would be a high-grade dysplastic nodule as indicated by the hypointensity on the hepatobiliary phase. Okay, HCC. Thankfully now we are a little more consistent in our interpretation, which I'll go through, but there are three key features of hepatocellular carcinoma, right? Arterial phase hyperenhancement, washout appearance, and capsule appearance. So here you can see the arterial phase hyperenhancement. Clearly this lesion demonstrates washout, and you see a nice well-formed capsule surrounding this lesion. This is diagnostic of HCC, and this correlates very nicely with what we see on pathology. And the key point here is that capsule has a lot of extracellular space, and so that extracellular space is where extracellular gadolinium is going to leak into and accumulate over time, very similar to what we're seeing with a scar on FNH. So classic appearances of FNH. This has led to the creation of LIRADs. How many people here use LIRADs in their clinical practice? Please, everyone, raise your hand. You guys don't raise your hands very high, but okay, maybe a third of you, it looks like. So you should all use LIRADs in your practice. And the main point of using LIRADs is because it will keep your interpretation consistent across readers at your site. Okay, before we introduce LIRADs, one person would say this is consistent with HCC, another would say concerning, and when they would use those terms would change over time. LIRADs keeps you very consistent. And so within LIRADs, there's this chart, and this is really the key to LIRADs. All you really need to know mostly is this chart and how to use LIRADs. And you'll see that there's a number of major features: arterial phase hypoenhancement, washout, and capsule, like we just talked about. But you should also remember that size and threshold growth are major criteria. And using these 5 major criteria, you can then categorize observations in an at-risk liver as being LIRADS 3, LIRADS 4, or LIRADS 5. Okay, and these have implications obviously in transplant lists and management as time moves on. So again, the major criteria, just to reiterate: arterial phase hyperenhancement, washout appearance, and capsule appearance, and then threshold growth. Threshold growth is defined as growth greater than 50% in maximum diameter in less than 6 months, or greater than 100% in greater than 6 months. Okay, and size is broken up between less than 1 centimeter, between 1 and 2, and greater than 2 centimeters. Okay. LIRADS also has things called ancillary features or ancillary criteria. So these are things that would make you think of HCC, but you can't use these features to up-categorize a LIRADS 4 to a LIRADS 5. It can only help you categorize something to a LIRADS 3 or LIRADS 4. And these include things like mild T2 hyperintensity, fat containing. If there's microscopic fat in a lesion, that's suggestive of HCC. If there's nodule appearance, if you have a large dysplastic nodule with an arterial hyperenhancing lesion in it, that's an ancillary feature. If you have restricted diffusion, that's an ancillary feature. Again, ancillary features cannot be used to up-categorize to a LIRADS 5, only up to a LIRADS 4, okay? So the key thing with LIRADS is major criteria: arterial phase hyperenhancement, washout appearance, capsule appearance, interval growth, and size. It's always good to keep in mind the transplant list, because that's really what the key point of the LIRADS or OPTN criteria is. So obviously, to be on the transplant list, you have to have a T2 tumor. So that means you have to have a tumor that's LIRADS 5 that's greater than 2 centimeters. Okay, so anything less than 1 centimeter obviously won't put you on the transplant list. And if you have a single 1 to 2 centimeter lesion, that won't get you on the transplant list, okay? But if you have a lesion between 1 and 3 centimeters, you can have up to 3 lesions, and if you have one over 3 centimeters, you get 1 lesion over 3 centimeters up to 5 centimeters, okay? The key point here, though, is you want your patients to get onto the transplant list, and when you call things LIRADS 5, that helps move them into the transplant list, whereas if you call it a LIRADS 4, they don't get MELD criteria for the transplant list. Last couple things are comments on EOVIS and gadoxetate in the diagnosis of HCC. So the last version of LIRADS introduced some ancillary features for using gadoxetate to characterize lesions as HCC. There are 2 ancillary features that suggest hepatocellular carcinoma. So one is hepatobiliary phase hypointensity, which is what you would expect. But there's one unusual ancillary feature, which is a hepatobiliary phase hypointense rim. So one thing we realize is that about 10% of HCCs are hepatobiliary phase hyperintense. And you characteristically see a dark rim surrounding that hyperintense nodule, which is indicative of hepatocellular carcinoma. If there's hepatobiliary phase hyperintensity, we call that indeterminate. It doesn't help you characterize something as HCC or not. And if there's hepatobiliary phase isointensity, that's suggestive of benignity. If you don't see it on the hepatobiliary phase, then likely that's not HCC. The one key point here also is that when you're using a hepatobiliary agent such as EOVIS, particularly with EOVIS, the 5-minute delay, you can't characterize washout on a 5-minute delay, because that's the transitional phase with hepatobiliary phase agents, because there's both hepatobiliary phase intensity, i.e. the liver is getting brighter due to accumulation of EOVIS within the liver, as well as washout all at the same time. So you can only characterize washout appearance on the portal venous phase when using EOVIS. So here's a case of an HCC with hepatobiliary phase hyperintensity. You see clear evidence of arterial phase hyperintensity, capsule appearance, and then it's classically dark, classic HCC with hepatobiliary phase hypointensity. Now remember, hepatobiliary phase hypointensity is not specific, okay? Other tumors such as cholangiocarcinomas, benign lesions such as a hemangioma or an adenoma can all demonstrate hepatobiliary phase hypointensity. Here's an example of a hyperintense HCC. I don't think everyone's always aware that HCCs can be hyperintense, but this is an HCC, right? Arterial phase hyperintensity, it becomes isointense in the portal venous phase, has a slight capsule, and then we have a hepatobiliary phase hypointense rim that surrounds this hepatobiliary phase hyperintense lesion, okay? Classic appearance of a hepatobiliary phase hyperintense hepatocellular carcinoma. So to review, imaging of the liver. One, we talked about imaging of diffuse liver disease. We talked about hepatic steatosis and how decrease of signal intensity on a post-phase imaging will be useful for the characterization of fatty liver. Iron deposition disease is the exact opposite. You get decrease of signal on in-phase imaging, and there are now more modern techniques using multi-echo sequences to measure the amount of fat and iron simultaneously so you can tease apart fat and iron. We talked about adenoma versus FNH and how hepatobiliary phase imaging or gadoxetate, EOVIS, can help characterize FNHs. And then I want to remind you of the diversity of adenomas. We have the inflammatory adenomas, T2 hyperintense, arterially hypervascular, versus the HNF1 alpha, woman with oral contraceptives, not that hypervascular, very low T2 signal hyperintensity, but it has microscopic fat, okay? And then finally, imaging of focal lesions in at-risk patients. Just to remember, hopefully you all start using LIRADS in your practice because it really helps create consistent interpretation across your practice, and our clinicians really like it because they know when they get the report exactly what's going on in the patient.